I found this very instructive and I learned a lot. And I would like to start with one question to Antoine. You showed the design of the PRODIGE 19 study, which is comparing a perioperative approach versus a surgery alone approach, you said. Nevertheless, if I saw it right and if I recall it right, patients who undergo primary surgery, they are also given the option of being given adjuvant chemotherapy.
It's not an option, it's mandatory.
Do you have, aren't you afraid that this may bias your results if many of these patients take this option?
It's not an option, it's mandatory.
It's mandatory.
Yeah. So adjuvant chemo is mandatory in the arm of treatment with primary surgery.
Do you think it was a good idea to design it like that and not going for surgery alone?
I think the 2 points, we can discuss the 2 points, but at the time that this trial was designed, we had at the standard arm the perioperative chemotherapy, and although the team of Guillaume Bayet showed previously that patients with surgery only did not benefit from perioperative treatment in a retrospective study, many oncologists and surgeons were not enough confident of treating their patient without any kind of cytotoxics. So therefore, we focus the trial with a so-called emergency to operate the patients first, because one hypothesis was during the perioperative chemotherapy, patient may progress, and it was very important to operate them on as soon as possible.
This is almost a discussion on prognostic versus predictive impact, because these patients have a very poor prognosis, that's clear. And the question is whether we should go for a glass half empty, saying they have a poor prognosis, but we have never shown that there is a benefit of whatever strategy. Or should we go and say, and that's what Antoine says, if I do the interpretation in a liberal way, is these patients have a poor prognosis, we should for sure give them a treatment because their prognosis is anyway bad, and you could then extend that to a strategy. The prognosis is so poor, we should treat them more aggressively. That's the attitude some people also have, and that's the dilemma in some of the discussions.
It is, yeah. But when I see the subgroup analysis, for instance, of intergroup 0116, which you also showed, which is showing no benefit of adjuvant chemoradiation in diffuse, and even maybe a detrimental effect in women with diffuse type gastric cancer, I could come to the conclusion that there is even a detrimental effect of doing something in this population. I just wanted to raise the question. Yeah. Thank you.
Excuse me, Florian, do you have another proposal?
No. No, no. I can understand
maybe the proposal in the
doing.
future, but that's not for today, is molecular-driven proposals. And you've shown that, Antoine, on some of the different subgroups, or was it somebody else, different subgroups, that the diffuse type and the Signet cells belong more a bit to one of the different subgroups in the TGA. Do you think we are ready, because extending that to metastatic disease, that we are ready to go for that, for specific trials in metastatic for the diffuse and Signet cells? I remember Jafra Jani started a few years ago a trial with S1, on S1-based chemotherapy regimen in Signet cell or diffuse gastric cancer. The trial failed, but they had some evidence based on some histological criteria and also based on some subgroup analysis in the FLAG study that the diffuse type or the Signet cells, that they had more benefit from S1-based chemotherapy. And that's just cytotoxics, but also in the future, looking at some of the new targeted agents, where can this lead us to?
I think the first thing to do is either to adopt a new classification for such cancer, and and those work from the Verona group are awaited. So maybe with this new classification we can identify patient with a lot of signal ring cells with better prognosis than the other. And the second thing to do is probably MSI too, to select patients who will benefit from chemo or not. And then when we have selected those patients, we can think about new future trial. But the first thing to me is to better characterize the population before to run a new trial.
Antoine, a direct question. If you have in your clinical practice in Lille or now in Montpellier, a young patient with a diffuse type, with metastatic disease, I'm extending to metastatic, good condition, who's willing to have a treatment, knowing that the treatment benefit may be not so good in a diffuse type with ascites and peritoneal metastasis, what would be your attitude in clinical practice to treat that patient more aggressively because you say we need more aggressive treatment because a doublet will not work and you will give her a triplet, him or her, a triplet of chemotherapy? Or will you say the treatment is not so efficient, I don't want to bother the patient too much with chemotherapy?
We treat him the same way than other patients. And regarding the triplet, I have read the experience for the German group, which showed that FLOT in the advanced setting was not so good. So we treated the patient the same way.
Florian, would you treat the patient with metastatic, the young patient with metastatic disease, a young woman, 45 years old, with ascites and peritoneal metastasis and a diffuse type Signet cell? Would you treat her in the same way than young patient with an intestinal type without ascites and peritoneal metastasis? Doublet, triplet, would be
yes, yes. To be honest, we don't make a clear distinction. I mean, when we are going into the discussion, if we use a doublet or a triplet, our algorithm is not based on the Lauren classification. It is really more based on the need to achieve a fast remission, on tumor load, on symptoms, on problems the tumor may make. So if there is a high need for remission, we go for triplets. If the remission pressure is not so high, we go for doublets. And for me personally, it does not make a difference currently if it's diffuse or non-diffuse.
Yeah, I completely agree. Okay. I completely agree. But you could say this patient is 45-year-old woman with a lot of tumor load, ascites, peritoneal metastasis. She probably doesn't have a lot of chances. And what you want to do is have tumor regression as soon as possible, more rapidly than in the intestinal type. So you could take the assumption going in this patient, putting her a bit more on a triplet therapy. That could be a correct assumption.
You can have this consideration, but you could also say that it causes more toxicity. You induce neuropathy earlier in the course of treatment. You may jeopardize the patient's condition on the long run. So I think there are arguments pro and con. And,
hopefully, there is a small percentage of these patients who are also MSI high. So maybe the few patients with Signet cancer with MSI high may benefit maybe from investigational treatment.
How much is that in your experience?
It's not my experience, it's what I read.
More or less zero.
10%, no?
No, that's too high for Signet ring cancers, no. I mean, it's more or less zero.
0%?
Yeah, it's very, very low. Unless you are obviously in an hereditary setting, coming from Lynch syndrome or something like that, it's extremely low. I mean, you can't say zero. There may be the odd case, but yeah, it's very, very low.
I have a question for you, Heike. You mentioned, or we don't have clear definition of Signet ring cell cancer. Maybe 90% will be right definition. And you mentioned that TCGA missed this group of patients. they didn't define the signet ring cell cancer in their in DCGA. So, do you think there will be some better tool how to identify this group of patients for the next trials?
I wouldn't say that they missed them, but we don't have that breakdown on the classification for them. So I think in contrast to the Asian group where you're having the WHO classification, we don't have that information at the moment. And we have now reclassified all the histology of the TCGA atlas because you can look at them. And so we're looking now at them, what are actually the percentages, and can we identify their more subgroups. But I'm not aware that anybody else has looked at that.
I would also like to get back to that, Heike, and maybe also ask Professor Seewald. After your talks, which were great, it is logical to me that this signet ring cell cancer definition needs to be more specified. And maybe the 10 to 90% and more than 90% is very nice. But do you believe that you will be able to do that on the grounds of endoscopic biopsies, where we have very few material, where maybe it's difficult to count these cells, or where you may jump into the whole problem of tumor heterogeneity? So where will we end with this classification when we have no more than some few endoscopic biopsies and all the treatment planning has to go from there?
I mean, when we had the consensus meeting, we didn't make any distinction on how we're going to classify biopsies or resections. So we would use the same rules. Of course, you can argue, is the biopsies, are they representative or not? But that's something we can't solve. But we would use or recommend to use the same way of classifying them, not having different rules for biopsies and resection. But of course, you have the problem with the heterogeneity, which you always have, and there's no way around that.
The point is also for us, the delineation of the lesion is the next problem. It's not only the problem that we don't detect the lesion, but the delineation is the problem. And when we only do a biopsy, that doesn't say anything. So that is a definite problem.
I have a question for Stefan. Stefan, you showed us this mucosal type signet ring cell cancer, and you showed us the criteria, the Japanese criteria for risk for lymph node metastasis. Do you have any experience in the same lesion of a polycohesive type without signet ring cells? Does that also exist, and are the same criteria, or how do they behave with respect to lymph node metastasis and your endoscopic criteria? Do they look different?
To be honest, we don't know this really. The problem is, from the data from the National Cancer Center, there were put all the undifferentiated types of cancer together. So there's no differentiation between undifferentiated intestinal type and signet cell ring type. And that is, I think, the major problem. We don't really know this. When we talk from mucosal cancer, signet cell cancer, then it is already an exposed type. And I think these are the cancers which will invade already into the submucosal space. So I think in the undifferentiated type of cancer, we see very early something endoscopically, more early than in the signet cell type. But I think there we have too little experience. And also there's only one paper treating this undifferentiated type of cancer by ESD. It's too less data, we honestly have to say.
In the well-differentiated, not the signet cells, not the diffuse, there is discussion on EMR versus ESD. Mm-hmm. Here it's always ESD.
Yes, so in the stomach, in such a situation, you always have to do an ESD because the piecemeal resection is completely out, because we have to provide to present the pathologist an en bloc specimen, also that he can make a very good histological assessment of the submucosal space. This is mandatory.
Yeah. Is there an additional role of an EUS in endoscopic ultrasonography in this setting in the evaluation? Because
no, I can clearly say in the early stages, EOS actually doesn't play any role. You need the time for the magnification endoscopy, and this is more reliable than any EOS.
Questions from the audience? Everything is clear?
Until a certain point.
Antoine, what is the next study apart from Prodige 19 you would like to do, to clarify?
In those patients?
Yes.
Only that one.
Only that one. That's the only trial?
Yes.
Any metastatic? Would you do a specific trial in metastatic?
Not yet. We have no plans, including in our network in France, for such patients.
Yeah.
And,
but you would love to do. You have a designing board. You have unlimited resources.
The word love is maybe too much, because I know it could be difficult to do a clinical trial with such patients, because you have to find patients in good condition, you have to find the patients, you have to find the funding, and it's not the best way.
You have unlimited resources. Suppose you have them. What would be your optimal design?
And yourself? Hmm? And yourself? What would you do?
Expert. Okay. Heike, what's your next subject you would like really to be answered within the next 2 years?
I think we need to solve the question we had this morning: how do we judge on the response of the diffuse type, Signet, poorly cohesive type? And I think we can only do this, again, like we had the Verona meeting, we can do this in a larger group only. We don't have enough cases, every individual people. So, but I think that's something we are planning.
And Stefan, same question, and where do you see endoscopy evolving with a mirror in the future for this, specifically related to this type of disease?
Well, our problem is how to find the patient and which groups of patients we should perform an endoscopy. Because I think in Japan the gastroscopy is very common because of the high incidence of gastric cancer, but in Europe it is not. We are too much focused only on the esophagus, on reflux and Barrett's cancer, and this is really, I think, one problem, because these lesions we only find in it's an incidental finding, and the patient has other symptoms not related to the cancer. But I also have no solution for this problem.
Okay, no questions from the audience? Thank you very much, all three, for the excellent contribution and talks. And yes.